Yeah, so despite the recent developments with new drugs in this space, we still have an unmet need. There's a large population of patients who don't respond to therapies. So there's still an unmet need. And so the rationale is to introduce another treatment here in the armamentarium we have for BCG unresponsive non-muscle invasive bladder cancer. Also, there are a number of patients who, large proportion of patients who are BCG exposed. And so, and for whatever reason, they didn't get additional BCG. As you know, we have a major shortage. So we want to include those patients. Traditionally, those patients have not been included in these clinical trials. So the CORE-008 trial is a prospective phase 3 trial, multi-institutional open label, looking at Cretostimogene, Genitourinary in patients with high-risk non-muscle invasive bladder cancer who are either BCG unresponsive or BCG exposed. So there's cohort A and cohort B stratified between the ones who are BCG exposed versus truly unresponsive. So it's a very inclusive trial looking at this high-risk population, this high risk of both recurrence and progression. So the way it works is the patients are registered and given the Cretostimogene once a week. And you asked about efficacy, I think, the way or how it works, the mechanism of action. It replicates specifically. This is a oncolytic immunotherapy. So basically, it enters the cells through the RB pathway, lyses the cells, and then elicits an immune response to the cancer cells. So this sort of a dual mechanism, if you will, of mechanism. Yeah, so we have good data already. So we have the BOND-003 trial that has been presented multiple times at different meetings. And so far, the CR rates at any time with the Cretostimogene in the BCG unresponsive cohort has been about 75%. These are very high numbers. So we're very excited about those trials. It's an ongoing trial with ongoing follow-up. And also, one of the things we saw in that trial is that a substantial number of patients who did not respond initially, reinduction was allowed in those patients, and those patients respond to a second dose. Duration of response, again, is ongoing, but it seems to be very good. If you look at the swimmers plots, you can see a number of patients are out beyond a year and still responding. So we're very excited. This is monotherapy with Cretostimogene. Prior to that, there was a trial looking at combination therapy with Pembro, but it seems like the efficacy with Creto alone is very, very high. Yeah, so there's a trial right now ongoing that's called PIVOT-006, looking at Cretostimogene in the intermediate risk patients. This is the AUA definition of intermediate risk patients who have recurrent low-grade papillary tumors or have high-grade tumors, TA tumors that are less than 3 centimeters. So this is a phase 3 randomized study that randomizes patients between Cretostimogene and observation. So the rationale for the observation is that we actually don't have a current a standard of care for intermediate risk patients. So there are a lot of trials trying to hone in on this in this patient population. The advantage is that patients who recur on observation are then allowed to go on Cretostimogene. So that's an ongoing trial in the U.S. called PIVOT-006. Yeah, it's a good question. You know, again, we need additional therapies, right? So I see this, you know, it's very well tolerated. We've known this for a number of years now from previous trials. So this is a treatment that's well tolerated. Also, there's a detergent that needs to be placed in the beginning. It's a multi-step process. So within this trial, we're also looking at a sort of a condensed version of putting the detergent in there to expedite and make it easier for the patients to tolerate the treatment in terms of just time. Overall, from a side effect profile, it's very well tolerated. So certainly we need this in our armamentarium of drugs to use in the future. We'd like to see sequencing, you know, how this falls into the again, the plethora of the drugs that we're going to have in the near future, and whether we can do combination therapy, whether, you know, the addition of chemotherapy plus an oncolytic immunotherapy, works. We already know that combination therapy with checkpoint inhibitors, systemic. We'd like to avoid systemic therapy as much as we can. So if we can keep it in the bladder, perhaps sequence them or somehow do additional therapies in patients, we can get better duration of response. We already know the CR rates are quite high. So that's what we're looking forward to seeing in the future.